Boom. All right. We have Paul Salamh here drinking his coffee. Sam's joined the party as well. Paul, thanks for coming on, man. How's your morning been?
My pleasure. No, thanks for having me. Morning's been pretty good. A little cold and windy here, but other than that, it's been great.
What does a little cold and windy even mean? Like how cold?
That's a great question. We had like 70-degree weather the other day, so anything below that seems cold. It's only like 40 something, so that's not really cold, but with the wind blowing in the 70s the other day, it feels that way.
Yeah, understandable. Sam, how cold is it in Canada right now?
Yeah, it's been pretty similar, like what Paul had mentioned. The last couple of weeks, we started to get some nice weather. I think we were like in Fahrenheit in the 60s. It's pretty nice. We started to lose some of our snow, but in the last few days, it's been below freezing again. So I think yesterday it was right around 25. So not loving that. Yeah, get me out of here.
Nice.
For you, Chris.
It's this classic Pacific Northwest weather. It's like 40 and rainy. Doesn't really snow. It just stays at this like kind of dreary, cold, but not a tundra. So I'll take it. I'd rather have that compared to California at the moment, which is chaos. Super snow.
Yeah, they've got something else.
Yeah.
They're definitely not prepared for it. Like, I assume Pacific Northwest is pretty good. I know Indiana areas used to snow. I lived in other places, man. They are not comfortable with snow and don't know how to handle it. It's just chaos.
No, when I lived in Texas 2 years ago, there was like the infamous Texas freeze where it just got wild because the whole system was down and we had no infrastructure to get anything rocking and rolling. So anyways, Paul, can you give us a little bit of a background of yourself? And then we can kind of go into this primary topic today.
Sure, yeah. I'm currently at the University of Indianapolis as primary role teaching. It's a teaching institution, so primary role teaching, but still loving research, so try and do as much of that as I can. Yeah, I don't know what else you might want to know about me. I've been there for probably about 6 years at this point.
Perfect. Where were you prior?
I was both finishing up my PhD and doing a faculty residency back at my alma mater at Duke. So I did a 2-year faculty residency prior to coming out to Indiana.
Nice. Thoughts on Indiana versus North Carolina?
Thoughts are there's not much of a comparison. I don't mean that. Indiana's great. We have great folks here. Not that there aren't great folks in North Carolina, but I'm watching Duke basketball on television as opposed to in person, so that doesn't help me out here as we head into March.
Got it. Okay. And is the accent North Carolina?
Oh, I didn't know I had one. It's whatever you want to call it. I don't know.
Where
I
are you
can play
born?
around with different accents, but this is not. There's no filter. This is just me.
Got it. Okay. Well, there's something there.
Okay.
All right. So the paper that we're primarily going to chat about is the piece you came out with Jeremy Lewis in 2020. So maybe we can chat about initially why y'all decided to write this viewpoint from JOSPT, and then we can kind of categorically go down into the different subsets of the paper.
Sure, yeah. I think this was something that had been on my to-do list for a little while. And it was really sort of my first introduction to doing things with Jeremy Lewis and getting to know him and work with him. So, golly, just in that of itself was phenomenal. And so from there, we've continued to build a relationship with research and various projects that we're working on now. But this idea was that we were obviously both passionate about the shoulder and moving things forward in the best way possible that we could see with current evidence and how we're practicing. And so we kind of set out to write this viewpoint as a meaningful, positively disruptive, thought-evoking paper in order to, kind of put it out there, right? I think there'd been a little bit of buzz here and there from certain groups and people and things like that, but we just want to kind of throw it out there in a way that was, I don't want to say loud, but in as much context as we could, supported but yet respectful, and just start the conversation. And from that, I've been grateful to both receive criticism and a lot of invitations to speak to great folks like you to kind of discuss it, right? To not necessarily promote it, but discuss why and have a conversation, I think, more around moving forward and examining individuals with shoulder pain versus this idea of just special tests for the shoulder. But how can we look forward and examine and treat patients in the most sort of the most effective way and current evidence-based and cost-effective manner.
And for, just so people are aware, it's the title is, "It is time to put special tests for rotator cuff related shoulder pain out to pasture." And who came up with that title?
Yeah, we threw a bunch of titles around. And I think, we owe a great bit, and which is why one of the reasons we acknowledged Claire Arden, who's the current editor-in-chief of JOSPT. It was almost sort of a question mark when we got to that point. It was largely Jeremy to throw the Pasture reference. I don't know if he has an affinity to cows or whatever. I have affinity to pigs, but I'm not sure. Maybe he can confirm or deny that. But anyhow, she had said, this doesn't need a question mark behind it. It's time. And for someone like her to say that, it was kind of that last little oomph that felt like, okay, we're doing this for a reason. And we have, especially for me, having someone like Jeremy Lewis being willing to co-author this paper with me, and Claire Arden to have a statement like that was just affirming and very, very nice. As I've always looked up to those and many other people in our profession.
And specifically, y'all are talking about rotator cuff related shoulder pain special tests. Can you briefly mention one of a handful of the more common ones that are taught still in grad school and that are commonly being used, and some of these, the ones that people are probably more familiar with, and maybe differentiating that compared to other tests for the shoulder?
Absolutely. So I think the thing to clarify is that, as you mentioned, these are rotator cuff related shoulder pain tests. And so atraumatic rotator cuff related shoulder pain. So we're not talking about traumatic type indicated tests, and we're talking about tests that are pain provocation tests as well. So pains that with a positive test would be indicated by reproducing pain in that individual. And so, things like the full can test, the empty can test, the Neer's impingement, the Hawkins-Kennedy, any number of those 70 plus tests that are currently being utilized in some form or fashion for rotator cuff related shoulder pain. So that could be related to the bicep, that could be rotator cuff, that could be labrum, again, non-traumatic. And I think that captures the first 2/3 of your question. The remaining is why maybe they're still being taught, or which ones are still being taught, or remind me there on that, or both.
Yeah, let's go. Yeah, probably both.
Yeah, so I think a majority of them are still being taught, right? I mean, it's kind of like, hey, today's shoulder test day in class, and we're going to run through all these, shoulder tests, and that seems like a great idea. And the rationale behind that, I think, is something we can talk about later. But I think a majority of them are still being taught. And when you ask, or when I get, how do I want to put this? When I get sort of some blowback from colleagues or folks that want to know, why are you not teaching these tests? That's a loaded question, and their follow-up is always, well, they're still being asked on the board exam. at least here in the United States, and that's a wonderful thing that they're still being tested on the board exam. However, I'm not teaching my students sort of what to learn. I'm teaching them how to learn and work through a process. And this is no longer an evidence-based approach of the process for rotator cuff-related shoulder pain in individuals who come see us. And so I don't see, this might sound wrong, but I don't see the value in spending time working through these simply to teach my students how to take a computer-based exam one day for a hands-on profession that they're going to do for the rest of their career. That's like teaching my kids about smoking by having them light up a cigarette, as opposed to teaching them why they might not light up a cigarette, and how to have meaningful conversations with people who do light up a cigarette and ask them to join them, not to disrespect them, but to say, hey, I choose not to because of X, Y, and Z. I don't have a problem that you're smoking a cigarette, but I'm not going to. And if you want to know, here are the reasons why, right? So we can engage in those conversations meaningfully, and maybe 1 out of 45 people put away their smokes during that conversation. You never know. So yeah, and that's another piece too, is that, I get, well, we are going to hear back from, we have heard back. I get this a lot from clinical instructors about they don't know all the special tests for the shoulder. And why is that? Who in the world is not teaching them all these special tests? It's your responsibility to be doing this. And I certainly have answers for them and welcome them to teach them those special tests if they want to. But the message I'm sending is sort of the message that we'll talk about today. But I think the bottom line is I want them to engage in meaningful, respectful conversations with colleagues, right? So we're all going to disagree on things. It doesn't mean that, there's a best way to do it or a right way to do it in our profession. But having an open and meaningful dialogue about it, I think, is important. So maybe that's a better strategy, is how to, teaching individuals how to have those conversations. And I didn't say students there because I think we could all learn how to have those conversations a little bit better from some of the things I see.
Yeah, to that point, Paul, last, I think 2 weeks ago, my clinic, it's a multidisciplinary clinic. So we have an orthopedic surgeon, PA, PT department, chiropractic department, athletic trainers, and we have a weekly journal club. And I brought this paper to the journal club, genuinely just asking each of these subsets of these providers, what do y'all currently use to diagnose pain in the shoulder, let's say non-traumatic events? And if you do use these tests, what is your hope and what are you interpreting? And it was a very civil conversation, even though there's some pretty big differences in a spectrum of views of like the utility or maybe the lack thereof. So I totally agree with your point of trying to have an adult conversation and not just bash a group for still utilizing it. From there, one, do you have any thoughts from that?
So, wow, thanks for bringing that to the group to talk about. That's nice. I think that's one of the hopes that putting this out there would be a mechanism for that conversation, or a segue into those conversations, that this was a digestible paper, a relatively short, that folks could read, come together, and then join in a conversation. And so it's nice to hear that it's playing out and at least being part of the conversation. So I appreciate that, and I hope that more folks might utilize it in that way. So we'll see.
Cool. So going into the paper specifically, you all on the first page talk about convergent validity with these special tests. Can you discuss, one, what that means, and then we can dive into these reference versus gold standards, comparing them?
Yeah, so there's a couple ways that you can look at validity of whatever it is you want to look at. And so if we're talking about these orthopedic physical examination tests, oftentimes convergent validity is utilized in order to look at a new something, right? So I'm going to develop this test or this tool to measure X, whatever that might be. So in this case, definitively determining whether or not someone has rotator cuff-related shoulder pain or impingement, to use an older word. And so how am I gonna, or actually rotator cuff tear is probably the best example, because if you're designing a test to detect a rotator cuff tear clinically, then you might say, well, what am I going to use to determine if this is a true positive or false negative? What am I going to measure this up against? It's got to be something relatively strong and sound, and which is where the term sort of gold standard or reference standard comes from, because it needs to be set up against that measure. So that measure in orthopedics is oftentimes MRI or some type of imaging, because on MRI, you can see the presence of a rotator cuff tear. So if that image that allows us to look inside someone's shoulder identifies that that rotator cuff is torn, then we can use that as a way to stack against our whatever tool we want to use to determine whether or not a rotator cuff tear exists. And I think that's sort of the germ of where this comes from, or part of where that foundation begins to be undermined with this specific conversation in regards to the gold standards, what they're able to detect, and more importantly, how that relates to the patient in front of us and clinical presentation, right? And I'll stop there, and if you want to go further, that's fine. We can maybe answer the next question. But that's the idea of convergent validity is when you're looking at validity and you're developing a new tool. When these tools were developed, when these tests were developed, a majority of them were compared to these gold or reference standards of MRIs or maybe an ultrasound image, something of that nature, since primarily what we're dealing with is soft tissue.
Yeah, so we can dive into the using this gold standard. Y'all in the next set or in the next topic go into reference standards. All that glitter is not gold, discussing why potentially these quote unquote gold standards aren't the best for determining prognosis, specifically the kind of lack of solid association between symptoms and abnormalities within imaging. So maybe we can dive into that.
Absolutely. I think there's a number of avenues to trek down here, and we'll start with the fact that although the MRI is definitive in determining whether or not, in our example, a tear of the rotator cuff exists, that may not be painful. So I think there's gobs of evidence to support that. I mean, we can look back at, Major League Baseball pitchers who have zero symptoms that show signs of labral tears and rotator cuff tears, and they're performing a task that is probably, or not probably, is the most demanding task that a human being can put its shoulder through based on the current evidence that we have, and that is throwing a baseball at a very high velocity. But they're able to do that without pain. However, when you image their shoulder, you see these abnormalities. And the study by Barreto et al. In 2019 is one of my favorite examples of this, where they brought individuals in, 123 individuals with unilateral shoulder pain. And they did an MRI on both shoulders. And there was really no difference in the findings of rotator cuff tears from their involved side versus their uninvolved side, with the exception of, I think, severe osteoarthritis and one other element in about 10% of the population. And so the point there being is that we know through histology, through anatomic studies, through normal individuals over the course of decades of research, that as individuals head into their fifth, sixth, and beyond decades of life, their rotator cuff becomes devascularized, you get fatty infiltrates, there might be osteophytes on the acromion, all sort of things that allow that rotator cuff to become torn as a senescent change, as our hair would get gray or we get wrinkles on our face. There's no real difference. It is a normal aging process. And so when you see an individual in front of you who comes to you for shoulder pain, they're having pain in their shoulder, and you examine them and you're able to reproduce their pain, and they get an MRI and they demonstrate a rotator cuff tear on MRI. Well, maybe a year or 5 years ago, if you did an MRI, they also might have had a rotator cuff tear, but no pain. So I think this type of evidence is one of the reasons we can begin to see that, yes, an MRI is a gold standard perhaps for detecting a rotator cuff tear, but is that correlated with an individual's symptoms and pain that they're experiencing? And I think the answer is no, it's not, at least not in all cases. There are a number of reasons why individuals can experience pain, even outside of nociception. And there are a number of structures in the shoulder that can cause pain. And you can open up this conversation beyond the shoulder. We can look at meniscal tests of the knee and have this very same conversation with regards to normal findings on MRIs being read as, oh, you have a torn meniscus or a torn rotator cuff, but you have no symptoms, right? Because all along in medicine, we're not imaging clinically people who don't have symptoms. We're imaging people who have symptoms. And then we find people who do or don't have tears. And so it's kind of, I don't want to say backwards, but when we begin to do the research on normal healthy individuals, we begin to see, oh, wow, normal healthy individuals have rotator cuff tears without any symptoms. And we can go as far as people with full thickness rotator cuff tears, conservatively doing well. From your folks up in Canada, there was a group of surgeons that followed people out 5 years with full thickness greater than 75% tears in their rotator cuff, and they did great. They had the option to receive surgery or not. And so, I think we're at a point, honestly, in the evidence that we need to stop chasing structures as a source of pain and look for why individuals are experiencing pain. We know now that there are multiple reasons why people experience pain in all kinds of constructs and facets. And so I think we would be a little bit presumptuous at this point based on what we know to think, one, that we can identify a particular structure that's causing pain, and two, that we can use a special test to isolate or bias a particular structure. And in the paper, we use the example of the empty versus full can tests and how many muscles are actively involved in those, when the idea is that we're trying to bias a supraspinatus tendon, when we know through histological exams that not only is the rotator cuff interwoven within itself, that there's no distinction between the tendon and muscle. I mean, that's basic biology, right? And that the rotator cuff is sort of interwoven with the capsule. And then we have the bursa, which has a high nociceptive property. And so if I can sit back clinically outside of an individual and perform a test that provokes pain and think that I have the knowledge and the ability to determine what structure that is, I think I'm fooling myself at this point. And I might be heading down a road that is more based off of, this patient has X and here's the treatment for X, and that's how I'm going to treat them. That's I think another part of the conversation I hope we get in eventually is why does it matter whether or not we use these special tests? What harm does it do? And golly, I think there's potential for harm that we might not realize because we've just been using them all along.
Can we go into the likelihood ratio discussion and pre and post test probabilities with these tests? And to your point, a lot of other orthopedic tests, whether it's surrounding the knee with meniscal tests, but one, maybe we dive into what is pre and post test probabilities and likelihood ratios and how these type of traditional shoulder special tests are very poor in regards to their likelihood ratios?
Yeah, so I think, to talk about pre and post test probabilities in their most pure form is that, a pre-test probability is a clinician's ability to create a hypothesis on an exam and have sort of some probability of what their hypothesis is being correct. So, if I'm examining this individual and I feel like one of my hypotheses is that they have rotator cuff-related shoulder pain, based on the presentation, what is my pre-test probability? What's the probability of me being accurate in my hypothesis? And at this point, in examining individuals with shoulder pain, I ought to have multiple hypotheses when I get to that point, because it's well, within a sense, and I don't want to get too far down that rabbit hole. And then a post-test probability is once you employ that test, how does that change the outcome of your examination? How does that influence your hypothesis? Does it remove it completely from the table, or does it obviously increase the likelihood of you being accurate in that assumption, and then basing your treatment off of that in some form or fashion? And so, there's even the old fashion in the research textbooks, on pre-test probability, that there's a line: if your pre-test probability is so bad, then obviously you look for another diagnosis, and if it's so great, then you don't even need to perform a test if your pre-test probability is so high in this individual, right? And so if you saw the mechanism of injury in a young athlete where the tibial was translated in a way that you would suspect an ACL tear, and they come off and they demonstrate all those signs and symptoms, well, that's probably a pretty high pre-test probability that they have an ACL tear. And then you employ any one of those tests for that structure, and the integrity is not as it is on the other side, then your post-test probability goes up, and then you can start to look at likelihood ratios, which are based off of sensitivity and specificity. And so, even if we were to look at those metrics in Chad and Eric Hagedis's book on the tests, which I know they're doing a revised or a new edition on that, you could look at those metrics, but those metrics are going to be based on our earlier conversation on how they stack up against gold standards, because you have to have your true positives, your true negatives, and all those things to calculate a lot of what we're talking about. And so, all those, I don't want to say all those numbers go out the window, but the foundation on which they lay begins to crumble. And so that's, I don't want to say it's a moot point, but we can't have one conversation without the other being firmly grounded. And we've already established that, comparing those to a clinical orthopedic physical examination test that provokes pain in a non-traumatic rotator cuff-related shoulder pain instance to an MRI finding isn't a gold standard at that point. And, it's not. And so then we can't even go forward and looking at some of those clinometric properties, because we don't have anything to stack it up against. That conversation has already been had.
So maybe we go into what would an actual comprehensive, I think we've harped on the point that there's really no value in performing these special tests. And if people have questions, well, then what do I do to guide my decision making during this examination? Y'all go into this outline and this table discussing what are some more of the recommended ways to go about this examination process. Can we go through what are the priorities if shoulder special tests aren't a priority and aren't giving us much information? What do you recommend during the examination process to guide decision making?
Yeah, so I think first, I think maybe those orthopedic physical examination tests give us information, but the only information they give us is that putting that individual in that position reproduces their pain. I think that's all we can say at that point, right? Not that it points to a particular structure or that this is involved or that might somehow guide our treatment beyond that. But the purpose of performing those ideally later on in your examination to confirm or deny your hypotheses goes out the window if I've already reproduced that individual's pain through a functional movement or an active range of motion, right? So a majority of the time, I don't want to say the goal of the physical examination, but part of what we're trying to do is find something that reproduces the individual's concordant pain or the pain that they're there to see you about. And so that might be their only ability, but I think there's probably more meaningful ways to do that than to perpetuate what they are. And so just to kind of clarify that, we do mention that a little bit in the paper, but beyond that, and we also mention that, if I've already reproduced their pain, then there's no need to, because at the very end of the conversations of the people who are starting to kind of understand this process, they say, well, at least I found the individual's pain during examination when I use this physical examination test. And I say to them, if I've done my job prior to that, I've most likely already found their concordant pain. And if I haven't, then I just need to rethink my hypotheses. But I don't need the tests to do that. However, the tests will do that, but I don't need them to do that. And also, I think teaching the tests implies their inherent purpose that's been purported, and it doesn't get to the root of it. So to the larger part of your question is, then what does a musculoskeletal examination look like for individuals with atraumatic rotator cuff-related shoulder pain? And I'll give the credit to Jeremy on this. It was his idea to create this table, along the way. He's like, if we're gonna put this out there as this being a bit disruptive and whatnot, we ought to put something out there that gives some context into current evidence-based best practice for an examination. And that's what we try to do in this table. And so I think, at the very end of my conversations with folks, if we haven't talked about this, I like to point them to this, because this is really where we want to be, is having conversations about how we're examining individuals with shoulder pain currently. So I appreciate you bringing that up. So it starts with the interview, right? It starts with getting to know the patient, letting the patient guide the interview. I think particularly for novice clinicians, and maybe even seasoned clinicians who build a habit, our tendency is to want to be that detective who goes in and we have this checklist of questions and we want to find the answer. We want to figure out what's going on by asking the right questions, when in reality, the patient is the only one who knows the story that they're trying to tell. And so we can oftentimes trip them up a little bit by trying to head in directions we'd like to go with our questions and not let them tell their whole story. Now, I'm not saying we can't ask our questions or be intentional about the questions we ask, but I also think we need to be more mindful about sitting back and listening and letting them guiding the questions. If it's the shoulder that's bothering them, but there's some biopsychosocial piece that's contributing to a great deal, if we focus on the shoulder and travel down that way in a very narrow path, we may completely miss out on something that they're trying to get across to us in some other manner. So I think it's important to have those. And so now I'll kind of go through these different components here, but the specific elements that are listed in this table, I think, are the real crux of kind of what we're going after. And there's more of them than you probably want me to speak about at this point. So I think the larger components, and we can speak specifically to any of the ones that you'd like to point out, but it starts with a comprehensive interview with the patient, right? And then we screen for serious pathologies, red flags. And so I want to know, at some point, am I looking at the shoulder here, or am I looking at something else, right? And I need to distinguish that. I need to distinguish, one, is it something big and scary that's not musculoskeletal? And if it is musculoskeletal, is it primarily from the shoulder? The cervical spine loves to masquerade as shoulder pain, but it's just not as cool as the shoulder. I mean, we all have to admit that. And so when I go through this process, I liken it to crossing the street, right? So before I cross the street to treat the shoulder, I've got to look both ways. I've got to look one way to make sure I'm not dealing with some sort of red flag, something that's not musculoskeletal, something that needs attention beyond where I'm going to need to go. And then I need to look the other way to make sure that this is primarily coming from the shoulder itself and not some other competing joint or multifaceted piece that I need to pay better attention to before I just head down the street of the shoulder. So as a clinician in today's world, seeing patients firsthand, I need to be prepared and confident in performing that, right? And I think a lot of it comes from the interview, a very sound, long, comprehensive interview. And then use functional disability questionnaires, all the way from related to the shoulder to kinesiophobia to whatever we're talking about that we think might be related to the shoulder. Then we assess the impairments. We go through our typical orthopedic examination that's outlined there, at least what we mentioned to be important to us based on the evidence. Then we provide them with education, advice, and we have that shared decision-making process goes into that at the end. So we have that shared decision-making conversation where we put out all the potential treatment options, including no treatment. It always has to be an option. No treatment is an option for patients, and they need to hear that. They need to hear that, sometimes history is a great healer. We know that time heals a lot of things. And so I will readily admit that earlier in my career, I probably got in the way of people healing and getting better without any help. I probably flared some individual shoulders up, and beyond my knowledge, I was trying to help them. But they've got to understand that here are treatment options, no treatment, and whatever it is that you feel based on the evidence is appropriate, and then the harms and benefits of all of those, right? And then you let them make that decision, even if it's not that day. They here's what I found. Here's your potential treatment options. Here's the harms and benefits of those based on what we currently know. I want you to go back to your family. I want you to talk to your priest, your shaman, your aunt, your uncle, whoever it is, and I want you to come back and tell me what you feel like is the best approach for you. Because I don't want to be so naive to think that. I think oftentimes as any profession, we think that if someone comes in the door to seek our service, then by golly, we're going to help them. Physical therapy is going to help you. And you're probably not wrong, but is it the most appropriate at that point in time? And I think that's something that gets missed because we feel like, and not just us, not just our profession, but I think any profession feels that way because we're so passionate about our profession and helping people that anyone who walks through our door, we want to help. But I think we have to be confident enough in our profession as well to know that we might not be the best person at that moment to help them. It may be somebody else, even if they never come back to us, or maybe they need some help with something else before they see us. But if we never have that conversation with them, it becomes very, this is what we're going to do, and PT is going to help you, and So I think that's something that's valuable. And you look to exceed their expectations along the way. And there's a lot of, I think, great little nuggets in those specific elements under these examination components that I would encourage people to look at and question, or email me if you've got questions about what do you mean by this, or what's the evidence behind this. I'd love to share it because I really think that this is kind of currently where we're at. This is what is valuable to patients who come see us for shoulder pain.
What are your thoughts, Paul, on within that examination going through like objective force testing or tolerance testing through handheld dynamometry? Typically, when I see a patient with this in this scenario, I'll go through like shoulder flexion IR and ER based testing and compare it to the non-painful side. And I am conflicted because they're in pain. So I'm going to assume that there's going to be a decrease in force production in maybe one or all of these positions potentially. But what information has that really given me besides like it's going to be painful to push at max, effort? So I go back and forth of what is this providing me? And then I try to justify it by, well, I can use these as goals as they're going to potentially get to 90% or above compared to the contralateral limb. And I can show them that this is their kind of current level of capacity in this position. But I'm curious to hear your thoughts of what is the early utility of that. If we already know that the shoulder's painful, this is just reaffirming that. do you recommend or utilize these type of tests with a more objective than a manual muscle test, or do you think it's unnecessary early on?
I think so. First of all, I think if you use it, you see some value in it, right? Because I see you as a thoughtful person, right? So, and this isn't something that you're just throwing out there because it's what you were taught or what you think you should do, but there's some rationale, and you've even explained a little bit of that, and it makes sense, right? It gives you a baseline to go off of. It gives you a place to objectively define goals. You're aware of the fact that, okay, if this individual is in pain, they may not be able to produce the same force as on the other side, but you're aware of that, right? It's also very telling if they can produce very similar force, but they're still in pain, right? So there's some value in knowing that as well. So I think that's great, and this is one of those conversations where I'm not going to stand here and say sit here and say this is something you shouldn't be doing, or this is something you should be doing. My goodness, we are in a profession where there is no right or wrong. There may be a better, but best sometimes is the enemy of good, because there's a lot of stuff that is in between there. And so, I think there's value in that. I also think there's value in looking at functional tasks and their ability to perform those to fatigue. Or maybe instead of weighted movements, we do weighted movements and repetition to fatigue or to pain. And so if it takes you, 24 repetitions to lift a 2-pound weight over your head until you get that shoulder pain, that tells me a little bit about your muscle endurance and fatigue. And, maybe I wouldn't have just saw that if I asked you to raise your arm up or perform a manual muscle test in a position that isn't very functional against a load that's probably not related to anything you would do in reality. But I think, the idea is that all this is coming from a good place, right? And so, but where's the balance? What's going to give us the most information to help this individual? And I think if that's objective measures through handheld dynamometry on force, whether it's lack of or near, with or without pain, I think that's a great place to start, right? And I think in my mind, I'm always moving, even if I start there, I'm always trying to move towards functional, because that's where I want to get them, right? So, if you think about strength and conditioning paradigm, and we're trying to sort of bias a particular muscle group with an exercise versus a very sport specific or work specific activity or function or strength atmosphere, I'm trying to get to that point. But these baseline measurements are helpful, just like with athletes, right? 1 rep max or 5 rep max to calculate a 1 rep max, or how far can they push a weighted medicine ball. We know, are they pushing a weighted medicine ball when they're out there doing stuff? No, but that's been shown to be reflective of their ability to perform X, Y, and Z task. And if we can improve their measure on that outcome, then we know that our strength program is making gains and that they're moving in the right direction. And we might expect to see that in their performance on the field, the pitch, the court, whatever it might be. And so I think, I think that's great. Good job, Chris.
Yeah, I think a couple other considerations with that too. Like, as you mentioned, when the individual's having shoulder pain, you could do repetitions to fatigue or repetitions to the degree of symptom onset. And with dynamometry, you have the same ability. Like, at what point do you push or pull into this device that you have an onset of symptoms? Because you might not have severe symptoms, or at least intolerable symptoms at rest. And so what point does it come on? And then can we look at other activities and how does that relate? Or during a functional task, you're not able to complete it. What are the underlying reasons that you're not? If you're not able to throw a ball because you have shoulder pain, well, what is the status on your isolated muscle strength testing? And is there any relation to that? If you have pain every time you go into layback, do you have pain with internal rotation? Okay, well, now we can scale that and look for ways that we can transfer that along the continuum to a more functional task.
Beautiful. That's a great point, Sam. And so I think, here's another thing to point out is we're having this conversation about all this handheld. At no point are we saying, well, if they get this measure on a handheld dynamometer, that you have a rotator cuff tear and we need to treat your rotator cuff tear. We're not pointing to a structure. We're looking at something functional for them, something that they can feel, something that you can see, not a structure that's at fault, because that gets into a much deeper conversation about, patients who know they have a rotator cuff tear and they're going to go through physical therapy. I've had conversations on the way back to an exam room, and a patient literally asked me, "What are you going to do to fix my tear?" I'm already behind the 8 ball. I'm already disadvantaged because they believe that their symptoms, their dysfunction, their shoulder is tied to that tear. And so therein starts the conversation of some of the potential harm that can happen by using some of these tests to do that. So, what we're talking about this whole time, we didn't mention anything there that was correlated to a structural abnormality. We were talking about pain, we were talking about function, we were talking about force production, all those things, which are all great things, and they're important to us and they're important to the patient.
Is there a time where you've ruled out the sinister things, there isn't this immediate need for surgery through a traumatic event or something that would warrant it as soon as possible? Let's say you've gone down the 1, 2, 3, 4 months of non-surgical treatment through kind of this progressive physical therapy or resistance-based program, and they're still in large amounts of pain, or they're still losing this ability to perform ADLs or their function. Is there a point where you do refer for further imaging, or they bring that up and they ask, is there more of a tissue-based pathology that I should take into consideration? What do those conversations look like? And is there more of a path to go down like this kind of pathoanatomical lens the further out they are from progress?
Yeah, I think the short answer is yes, right? And so in that table we talk about the sort of the physio, if it's decided on by you and the patient through that shared decision-making process, that you're going to implement a program that's about 3 months in length. It's not we are not a hoop. We are not a hoop to jump through for insurance providers to get surgery, and we're not a 3 times a week for 4 weeks hoop. That's not. I don't understand that, I guess. And so, we need to give it a fair shake. We need to give it time. And so if you were to say to someone, "Well, we're going to need 3 months of PT to see how this is going," you're like, "Wow, that's a lot of PT." Well, yeah, but maybe not 3 times a week, maybe not 2 times a week. Maybe we see how it goes. But the idea is that we need to allow time for this to work. It's not something that's just going to happen within a week or two. We're going to need time for this to play out and see whether or not it's effective in helping improve your function, decrease your pain, whatever it is you're looking to get out of this. And so at the end of that time period, if it appears there's there hasn't been any gains made, they're not heading in the right direction, first of all, I would hope as a clinician, I would be back to the drawing board multiple times up to that point, right? I'd be reaching out to colleagues. I'd be talking to my fellow clinicians. I'd be saying, "Hey, it's just, am I missing something here? Here's what I saw with this patient, or would you mind taking a look at this patient alongside me and see, what I might be missing?" And some conditions, even after the most thoughtful and intentional program, after 3 months, they may not get to where they want to be. Right? It may not be that they're still in pain or they're at their baseline when they came to see you, but maybe they're not where they want to be, and they don't see the value in continuing on with that program, even though they've made progress in your eyes. At the end of the day, it's not our shoulder, it's theirs, and so the progress has to be seen in their eyes to a satisfactory goal. And that gets back to, again, sorry I keep mentioning bigger conversations, but expectations. Aligning expectations early on with patients, so that their expectations aren't, "Hey, in a month or two, I'm going to be 100%, right?" And in your mind, you're like, "Oh boy, it's going to take a long time. At 3 months, you're still going to be caring for this thing, but a majority of that care is going to be on your own. And part of this process is me educating on you how to take care of your shoulder. And so if that conversation is never had and you're both having those stark thoughts in your head and you get to 3 months, in their mind, it's failed. In your mind, it's going well. But you don't have that conversation until 3 months. So that, I think, sometimes can be a pitfall too. I think that's important in planting that seed early on to allow the whole process to grow. I think that's important for both the therapist in this case and the patient. So absolutely, I think those conversations need to be revisited, not just at 3 months, but along the way of, how is this going? Is this going? Are we, based on the conversation we had early on, and you chose to go down this route of having physical therapy for your shoulder pain, not I chose it for you, but you chose this route, and I'm willing to work alongside you to help empower you to manage your shoulder pain. Where are we at 3 months, right? Where are we at 1 month? Where are we at 2 months? And that conversation then begins to blend to the point where you're not really having that conversation at 3 months, you're having that conversation along the way. And maybe the patient's making a decision at three plus months on what it is. And so you're certainly going to reach out maybe to your orthopedic surgeon colleagues or your non-surgeon orthopedic colleagues or whoever, that you might reach out to have that conversation, do further evaluation on that patient, because there's a lot of reasons why folks may not be getting better with physio. And part of it may be that they've had enough. They've had enough of, there's so much going on in their life, or they don't have time to make it to this appointment, or they're not willing to put in the work. And we can't sit there and force them or badmouth them because they don't know their home exercise program or because they're not willing to put in the work. No, that's life, folks. We can't, we're not here to judge people. We're here to help people. And so if they're not at a place to receive that, and something else is going to get them better, then we need to be willing to step aside after we've done what we feel like we can do and help them move to the next step, not wash our hands with it and say, oh, fine, go see the orthopedic surgeon then. It's not that kind of conversation. It's, hey, do you mind if I, reach out to the orthopedic surgeon? We have a conversation before you go see them, or I'm happy to, it's I think we can do a better job of that piece too. And so I think we need to be well aware of the fact that there's more going on with a lot of folks than we realize. And we may not be able to help everybody. And I think that's something that people going through training need to understand too, because we can beat ourselves up pretty bad if our goal is to help everybody, because we may not be able to, if that makes sense.
That does make sense. This is kind of a shift in the that particular topic, but going to your current role as primarily a teacher and educator, is it, when you have this discussion with your students, does it feel like there's hesitancy to not want to immediately anchor an exam to the special tests or trying to find some certainty there? Or does it almost feel like a breath of fresh air to them that they can sit back and focus more on the history and the subjective nature and this conversation, and then guide it more based off of the priorities of the patient and the functionality of what they want to get back to? What have you noticed when teaching patients and maybe pulling away from a pure memorization of these potential dozens of special tests that they could do in an exam?
Yeah, I've seen both. And I've seen the contrast in both ends, and I've seen everything, maybe not everything, but a fair number of things in between. And the other thing is that I'm teaching my content, the upper extremity. And so I also have to be mindful that this is my lean, good or bad, on this particular area, and that I've done some research in this area, and I think this is where best practice is, and so that's what I'm going to teach you. And we've had some hard conversations in class where They're looking for a diagnosis. Why are you not walking me through the different diagnoses that could be occurring in the shoulder, and talking about how those present and how they're treated? And I think one day I may have had enough of that. And so I wrote on the board, this is patient whatever, and here's your diagnosis. How are you going to treat them? And their comments were, well, we didn't perform an examination. We don't know how to treat them. And my point was, yeah, that's right. So it's not the you have to go through the comprehensive physical examination to determine how you're going to help this individual. You could put 100 patients under the diagnosis category of whatever they were diagnosed. And I think if you go through a comprehensive examination, as we've outlined, specific to the shoulder, your treatment is going to vary widely based on the needs that they present to you differently. And so I one of the things I will get to, and that my students will know when they hear it, is that you're treating what you find objectively in the context of your subjective examination, meaning that the person in front of you, they may have weakness in this and weakness in that, and they might look like the same objective examination, but subjectively, meaning they're different people, they have different needs, they come from a different perspective, they've walked a different road in life, then you're going to treat what you found objectively in the context of who that person is. And so a special test gives you none of that. A comprehensive physical examination is going to give you that. And so it's something to wrestle with, right? And the board exam gets brought up to me either by students or colleagues, and this idea of you're going to need to give a diagnosis, and you're going to need to have it. Okay, great, they have shoulder pain, and we're going to move on from there. And or how do you have conversations with a patient who want a diagnosis? Well, you can have those conversations without naming a structure, or you can reframe what another health professional has told them about a diagnosis. Now, does that mean that you might have to work a little harder or your narrative is a little bit different? Absolutely. And that goes back to my point of treating your objective findings in the context of your subjectives. So if you don't know who they've seen or what they've been told or their attitudes and beliefs about certain types of treatment or what treatment they've had before, you have no idea how to frame your treatment in the context of what you found. And so there is just nothing that can replace that. And we have this healthcare system that is sort of trying to squeeze all of that out of an examination, particularly for physios, but it's not unique to a general physician or an orthopedic surgeon that you need to see this number of patients in this number of time. The first thing that's going to go out the window is the conversation, because that's what, at least for me, that's what takes the longest, is the conversation with the patient. And so if that goes out the window, then I feel compelled to lean on these other things like orthopedic physical examination tests or a really quick set of objective pieces that are going to show me what I should be doing with this patient.
Boom. I just took the boards less than a year ago. I don't remember any shoulder special tests, if that means anything.
Well, yeah, it's interesting. When we were writing this, I reached out to the board and I said, hey, we're writing this paper. I was wondering if we could have a dialogue about, what is currently on there, or if there's, what changes, because the evidence is current. And basically, it was, we have our process and procedures. They're like, but we can tell you that basically at the end of the day, it's a matter of, knowing if this test is positive, what does it indicate? Well, I don't need to spend time going over that in class. You can read that and answer those few questions that are on there. I mean, again, at the end of the day, as a student paying more money than you probably should to listen to me lecture and show you, what I think you should be doing, it's not time well spent on those things. It's more about how do we help people? How do we connect? How do we treat that individual in the context of what we find?
What?
Yeah, obviously this
Sam,
is a bigger, yeah, obviously this is a bigger topic than what we're currently discussing, but I see the boards often gets blamed for a lot of the reason things are taught in school. I remember when I took the boards, and again, I took it in 2017, and preparation was very frustrating. I felt like there was going to be all these different questions, but then when I took it, I don't recall there being a lot of inappropriate questions or things that I thought were completely irrelevant or unnecessary to be asked. I was one of the first years that had a lot of questions about lymphedema, and that was definitely overwhelming because I did not prepare for that. But outside of that, there was, I remember there was some questions on different treatment choices, which I thought were, really gray. But I don't recall special tests or things hyper-focused that I couldn't easily answer.
Paul, what currently, if you're able to talk about it, what is your research and area of interest going down at the moment? What are you hoping to publish in the next few years?
Yeah, so kind of excited with the help of Jeremy. I've kind of narrowed my focus into the world of frozen shoulder. I still do a little bit with obviously different sports and athletes and performance and things like that, and baseball. I don't think I'll stop studying effects on pitchers and fatigue and pitch load and stuff. I have some good colleagues and friends who work in those areas, so I like to be a part of some of those things. And my son plays baseball, and I help coach, so he's a pitcher, so it kind of it makes sense. So I do it, but I think the bigger piece is with regards to frozen shoulder, and so I think I can speak about this because I think Jeremy spoke about it in one of the interviews he was doing, so I feel like that's appropriate. Myself, Jeremy Lewis, Rachel Chester out of the UK, Albert Lou, who's working with our stats, and then a local orthopedic surgeon, Evan Armington. I'm helping to lead what's called, we're calling it the MELT Frost study, and so we're looking at the possibility of subgroups within individuals who have frozen shoulder. So kind of trying to carry on Louise Holman's work, where she looked at the range of motion of individuals about to have manipulation under anesthesia with capsulolysis, looking at their range of motion in the glenohumeral joint, specifically pre and post anesthesia. So the idea is that we believe that there's a subgroup of individuals who present as frozen shoulder because it's a diagnosis of exclusion. And if you meet the criteria, then it's sort of you have frozen shoulder, but there's probably a subgroup of individuals more than we realize who are either guarding, fear avoidant, have kinesiophobia, who present very similarly to a classic frozen shoulder, but have no true anatomical restriction. And so we're capturing them at their first visit, giving them some information about sort of different biopsychosocial pieces and their lean towards different types of treatment. And then we're following them along the way. And if they end up having surgery for that, then we're measuring their range of motion pre and post anesthesia. And the thought is that if we can kind of get a sense of who those individuals are and some of their characteristics and traits, we might be able to capture that subgroup earlier on, and sort of provide instead of a one-size-fits-all treatment approach to those individuals, maybe sort of a unique treatment approach for those individuals who may not have a true anatomical restriction for frozen shoulder.
Very cool.
And then a bunch of other stuff related to that. Try and understand more about frozen shoulder than I currently do. Just like everything else.
Awesome. Last question. If people were watching this on video, your dog made an appearance. What type of dog do you have?
Yeah. I have two wire-haired pointing Griffons. They're finished gun dogs. And so, he was the smallest of the two.
Nice. Sam,
thanks for catching that.
Yeah, that was great. I could hear the little collar and jingles and then saw their little body pop up. Is wholesome. Yeah. Sam, any final thoughts or questions before we wrap it up with Paul?
No, that was fantastic, Paul. You were stellar. Thank you.
I don't know about that, but I appreciate the invitation and always welcome any conversation you folks want to have.
Yeah, when the MELT, is that what it's called, the MELT trial? MELT
Yeah,
paper?
mindful elements linked to frozen shoulder, so melt frost.
Yeah, when that comes out, we'd love to have you back on to talk about some frozen shoulder.
Yeah, that'd be great.
Perfect. Thanks again, Paul.
You got it. Thanks, guys.